Hello, and welcome to this two-part presentation on myelosuppression as part of the FIP and ISOPP CPD BITES program. My name is Nick Duncan, and I'm a consultant hematology pharmacist based at the Queen Elizabeth Hospital in Birmingham in the United Kingdom. Today, I'm going to be talking about the three most important forms of myelosuppression: neutropenia, anemia, and thrombocytopenia. I will cover neutropenia in the first presentation, and then anemia and thrombocytopenia in the second presentation. For each topic, I will be focusing on the etiology, risk factors, presentation, prevention, and treatment. When we are considering side effects of chemotherapy, it is important to think about our patients and their perceptions, as well as our own. Before I reveal the answers to these two questions, I will give you a moment to think about them. It is interesting that when patients are asked to rank side effects in terms of relative importance, the two that tend to stand out are nausea and vomiting and hair loss. But when healthcare professionals are asked the same question, it is myelosuppression that tends to be our number one concern. So it is important that we educate our patients about myelosuppression, what it is, and what are its implications, as it may not be an aspect of their treatment journey that they are highly focused on. And this leads nicely on to the next slide. We know that myelosuppression is very common in patients receiving cancer treatments, and it can have significant physical, emotional, and financial impacts. For example, infections associated with neutropenia may be fatal. Patient quality of life can be negatively affected, and the need to dose reduce or delay treatment in patients who develop myelosuppression can lead to a reduction in overall dose intensity, which we know can potentially compromise clinical outcomes. And finally, there is an economic burden associated with the prevention and treatment of myelosuppression. Given that conventional chemotherapy targets rapidly dividing cells, the bone marrow is therefore an obvious toxicity target for most conventional chemotherapy drugs. Myelosuppression is the dose-limiting toxicity for most agents, and rather than try to remember all the drugs that cause this effect, it is probably easier to remember the exceptions. For example, vincristine, which is the least myelosuppressive of the vinca alkaloids, and bleomycin. It is also very important to remember that chemotherapy spares the mature differentiated cells, but kills the immature cells in the bone marrow. So when mature cells die naturally, there aren't enough new cells to replace them. This leads to neutropenia, thrombocytopenia, and anemia. And this explains why these effects are not immediate. And in the case of anemia, when you consider that a red blood cell has a half-life of approximately 120 days, it may be a number of months into treatment before clinically significant anemia is seen. Neutropenia is the most important hematological toxicity due to the risk of life-threatening infection. As you can see, febrile neutropenia is relatively common in patients receiving chemotherapy, and in those patients who are admitted to hospital with febrile neutropenic episodes, the mortality is significant. Predisposing factors for infection include, firstly, the depth and duration of neutropenia, as I will show you in the next two slides. Loss of cell-mediated and humoral immunity. This is particularly relevant in the hematology setting, where corticosteroids and monoclonal antibodies targeting lymphocytes are often used. It is therefore important to watch out for lymphopenia as well as neutropenia, and to think about the risk of opportunistic infections such as pneumocystis jirovecii pneumonia or PJP. And finally, mucosal damage is another potential predisposing factor. This slide nicely illustrates the most common pattern of neutrophil count following on from a dose of chemotherapy. The size of the shaded area, which measures the depth and duration of neutropenia, is critically important, as you can see in the following bar chart. It is noteworthy that even patients with a relatively short duration of neutropenia have a significant risk of serious infection, and that risk increases as the duration of neutropenia increases. This slide summarizes some of the key risk factors for neutropenia and allows us to risk stratify patients and then consider preventative measures in higher risk groups, for example, older patients or those receiving very high doses of chemotherapy. In terms of preventative strategies, the simplest option is often to delay or dose-reduce chemotherapy. But because this may have detrimental effects on disease outcome, intervention with growth factors, such as granulocyte colony stimulating factor, GCSF, or the use of prophylactic antibiotics may often need to be considered. Whatever intervention we introduce is not expected to prevent neutropenia entirely, but the aim would be to reduce the depth and duration of the neutropenia and therefore reduce the risk of infective complications. And as we will discuss in later slides, patients who present with neutropenia and fever need prompt treatment with broad-spectrum antibiotics, as this is regarded as a medical emergency. GCSF, usually filgrastim or lenograstim, is not used universally, but should be reserved for high-risk groups, driven by the factors mentioned in the earlier slide. I think that the main driver of this is an economic one, as these drugs are expensive, and so the cost-benefit ratio of intervening needs to be considered. There are many reputable international guidelines that can be used as a template for local policies, and I'm showing the most recent ESMO guidelines as an example. Antibiotic prophylaxis has been a strategy for many years, but remains somewhat contentious. I think that this recent large meta-analysis nicely illustrates some of the key pros and cons of this approach. And as well as being aware of the downside of the increased risks associated with antibiotic resistance, as pharmacists, we should also be thinking about the side effects of these drugs and their costs. This figure nicely illustrates the fact that antibiotic prophylaxis does have some benefits in terms of time to and rate of infection, but it is not a panacea, and even in those patients receiving prophylaxis, some will still go on to develop infection. For the last part of this presentation, I just wanted to briefly mention febrile neutropenia, appreciating that this could potentially be a whole talk in its own right. The European Society for Medical Oncology, ESMO, defines febrile neutropenia as an oral temperature of greater than 38.3 degrees Celsius or 2 consecutive readings of greater than 38 degrees Celsius for 2 hours, and an absolute neutrophil count of less than 0.5 times 10 to the 9 per litre, or a count that's expected to fall below this level. And as has already been stated, febrile neutropenia is a medical emergency and requires prompt treatment with broad-spectrum antibiotics. I'm afraid that we don't have time to go into its management in detail, but the main point to get across from this slide is that risk stratification is often used to guide treatment. And it is also important to be aware that the evidence base for using GCSF in the treatment of febrile neutropenic episodes is much weaker than that for its role in prophylaxis. I've used the most recent NCCN guidelines as my reference, and you can see that only specific high-risk patients should receive this particular intervention.